Hello everyone, in this video we would be taking a look at multiple gestations. So let's begin. So mainly it would be causes, clinical features, investigations, diagnosis and management, and we will take a detailed look at the conduction of delivery of second twin. So it's twin pregnancy, right? So there is the first twin, second twin, and based on how the presentation is and all that, the conduction of delivery varies. So that is what we are going to take a look at. So what's the overview? Let's take an overview. A multiple gestation refers to simultaneous development of more than one fetus in the uterus. Twin pregnancy is the most common form and classified as dizygotic or monozygotic. So two zygotes formed here and one zygote formed here, and the incidence varies globally and based on the race, heredity, maternal age and assisted reproductive techniques. Coming to the causes. So dizygotic twins, fertilization of two separate ova by two different sperms, more common in older mothers and associated with ovulation inducing drugs and assisted reproductive techniques. So multiple zygotes are formed, multiple zygotes are present, and these are from different sperms altogether, and assistive reproductive techniques are one of the major causes. And also overall ovulation induction drugs too. Next, coming to monozygotic twins. So just one zygote is present, occurs due to division of a single ovum. The timing of division determines the chorionicity and amnionicity. So we talk about chorionicity and amnionicity only in case of monozygotic twins, and that is not present in case of dizygotic twins. So all the dizygotic twins are these dichorionic, diamniotic, which is completely different altogether, like different chorions, different amnions. But in this particular case we have four different types. So first one, depending on the time of division, so 72 hours, 4 to 7 days, so 3 days, 4 to 7 days, 8 to 12 days and 13 day after day 13. So from the beginning it is, if the division happens very early, it is dichorionic, diamniotic, which is 25 to 30%. If it is somewhat late, it is monochorionic, diamniotic, which is 70 to 75%. Monochorionic, monoamniotic, it is 1 to 2% and day 8 to 12. And finally conjoined twins. So chorion refers to the placenta which is present, amnion refers to the amniotic sac. So clinical features of twin pregnancy. So increased uterine size disproportionate to the gestational age, because there are multiple fetuses present. Exaggerated pregnancy symptoms such as nausea, vomiting, dyspnea and palpitations. Increased fetal movements due to presence of two different fetuses, and palpation findings including palpation of too many fetal parts, fundal height exceeding gestational age, and two distinct fetal heart sounds separated by a silent zone. So these are the a very intuitive understanding, no need to bang the head. So coming to the investigations and diagnosis. So first one being sonography, ultrasound examination. So we have first trimester detection, second/third trimester detection. So identification of two gestational sac, that is for first trimester, and a determination of chorionicity and amnionicity using twin peak or T sign. So in case of twin peak sign, there is dichorionic, diamniotic, and in this T sign it is monochorionic, monoamniotic. So I have the difference over here mentioned. So let's take a look once. So it is a triangular projection. In case of twin peak sign, it is a triangular projection which is lambda sign, which is also known as lambda, which looks like lambda, so that's why it's called as lambda sign. And there are presence of two separate placentas, so it is dichorionic and low risk of complications. So that is twin peak, so two different peaks. But the T sign, it is monochorionic, diamniotic. So one chorion, only a single shared placenta with two amniotic sacs. That's why it looks like a T, and it is a straight T-shaped membrane. And there is high risk of twin to twin transfusion. So let's look at an image. So first we'll look at one is the twin peak sign. So Yeah, so here you can see lambda sign, wherein there is lambda shaped kind of a thing, lambda, and there are 2 chorions, 2 amnions. Everything looks much thicker here. Yeah, but in this particular case it is a monochorionic but diamniotic, which is T sign. Yeah, next coming to, which is this is an important category, and next coming to the second and third trimester, assessment of growth anomalies and twin to twin transfusion syndrome, which is seen in particularly in the monochorionic twins. Doppler studies or vascular for vascular anastomosis. Coming to biochemical markers, increased maternal serum levels of beta hCG, because there are multiple placentas, multiple fetuses, so overall the beta hCG levels increased alpha fetoprotein levels and estradiol compared to singleton pregnancies. Genetic testing, DNA fingerprinting and blood group testing to differentiate monozygotic and dizygotic twins. Yeah, coming to antenatal management, when we actually realize that it is a twin pregnancy, what do we do? So first one, increase nutritional support, additional 300 kilocalories per day with increased protein intake, and also we need to increase the iron, calcium and folic acid supplementation. There are specific numbers for each of these, but overall this is what we already have too many numbers, but so this one should be enough. Frequent antenatal visits every 2 to 3 weeks for monochorionic twins and every 4 weeks for dichorionic twins. So 2 to 3 weeks for monochorionic, 4 weeks for dichorionic. Serial ultrasound monitoring from 24 weeks onwards to detect fetal growth restriction, twin to twin transfusion syndrome and discordant growth. So, and then coming to hospitalization for high risk cases, preterm labor, severe growth discordance or preeclampsia. For these particular things, we hospitalize the patient. Intrapartum management, so during the delivery, mode of delivery, if vaginal delivery, if the first twin is in vertex presentation and cesarean section indicated for non-vertex first twin. So this we would be going in a lot more detail in the coming section over here. So and but just overall in brief, monoamniotic twins, severe TTTS and conjoined twins. And we have been seeing this TTTS repeatedly, so let's see what this is. Transfusion syndrome, the serious condition in case of monochorionic diamniotic twins, where there is single plasta interconnected blood vessels. So there is imbalanced blood flow between the twins and due to abnormal vascular connections. So the donor twin loses blood, and because of it there is hypovolemia, growth restriction and anemia in that particular twin, and that sac there is oligohydramnios, but in the other twin there is hypervolemia, polycythemia, cardiomegaly, heart failure and excess of amniotic fluid. So that is twin to twin transfusion, one twin to other twin transfusion. And yeah, coming to the timing of delivery, dichorionic diamniotic 37 to 38, monochorionic diamniotic 34 to 36, so slightly earlier, and monochorionic monoamniotic more earlier than that, 32 to 34. So we are decreasing it by how many weeks? So 37 just by 1 week here, and the same 32 to 34, 34 to 36 and 37 to 38. Complications of twin pregnancy. So maternal complications, fetal complications. Maternal, it is losing a lot, mother is losing a lot more nutrients, so there could be anemia, gestational hypertension because of, these are because of excessive load, gestational hypertension, preeclampsia, antepartum hemorrhage, postpartum hemorrhage due to uterine over distension. Fetal complications including vanishing twin syndrome, so twin to twin transfusion syndrome, preterm birth, intrauterine growth retardation, restriction, cord entanglement in monoamniotic twins, because it is just one sac and it might become convoluted and cord might get entangled. Now coming specifically to the conduction of delivery of second one. So there are principles and stepwise there is a stepwise approach to doing it. So to conduct it, yeah. So principles. So second one is at risk due to placental insufficiency after the birth of the first one, and expedited delivery is essential to prevent fetal hypoxia. So do it as soon as possible. So, but unless there are some conditions where you don't do it. So, stepwise approach: after birth of the first twin, assess the live presentation and fetal heart sound of the second twin. Perform a real time ultrasound if required. So, that is the first step. Next, do the, so when you get the lie assessed, if it is a longitudinal lie, there could be two cases. It could be a vertex or breech. So, if it is a vertex case, vaginal delivery with oxytocin if necessary. So, normal. So, normal which is lie, and normal vertex, and normal delivery vaginal. If it is breech, we do breech extraction. Breech, we would, there is a separate section on breech, we lower somewhere over here, abnormal presentation. Yeah, you can take a look over there. Transverse lie, attempted external ECV, external cephalic version. If unsuccessful, performed internal podalic version with and breech extraction. So, that is transverse lie. So, lie meaning the baby's fetal pole and the head pole, like the two poles are in the longitudinal, top to bottom, superior to inferior. But in case that, and that particular case, we do this. But if the transverse lie, the baby is like this and the meaning like this, it is in cross section. In that particular case, you do the external cephalic version, or internal, if that doesn't work, internal podalic version, and then breech extraction. Delivery methods: vertex presentation if low down, forceps assisted delivery if high up, internal version or cesarean section if cephalopelvic disproportion is suspected. So, and then breech presentation delivered by breech extraction, and transverse lie, internal podalic version and breech extraction under general anesthesia. This we have seen already. Delayed delivery: in rare cases, the second one is delivered after days to weeks if membranes remain intact. So, that is what I mentioned. It is sometimes if the membranes are intact, you just leave it there. Post delivery management: monitor postpartum hemorrhage, monitor for postpartum hemorrhage, neonatal assessment for growth discordance, TTTS, and anomalies. Yeah, and with this we come to the end of the topic, the video on multiple gestations. In case you like this video, you can like it. In case you would like to watch more of such videos, you can subscribe.